I'm really delighted to welcome you to the Gandhi Memorial Lecture, which is a highlight event in the Institute's calendar initiated by our founder, Professor C.V. Raman. The Gandhi Memorial Lecture was instituted by Gandhi Smarak Nidhi in 1959 to be delivered at the Raman Research Institute by a person of high eminence on the Gandhi Jayanti. The lectures were delivered annually by Sir C.V. Raman, with the last talk a month and a half before his demise in 1970. After his demise, the Raman Research Institute Trust formally managed them in conjunction with the Institute. Speakers are selected not only for their eminence, but for their concern for humanity and social services, which were close to Gandhi's heart. We are pleased that the 51st Gandhi Memorial Lecture will be delivered by Dr. Abhay Bang. Working with his spouse, Dr. Rani Bang, they are widely respected humanists, activists, and community health researchers working in the Gadchiroli district of Maharashtra. I request Professor Jyotsna Dhawan, chairperson of the RRI Trust and a leading researcher at the Center for Cellular and Molecular Biology, Hyderabad, to welcome the guests on behalf of the Trust and introduce our speaker. Jyotsna.
Thank you, Professor Sarathy. Welcome, everyone, friends, and welcome, Dr. Bang. On behalf of the Raman Research Institute Trust, it's really, is it on?
Yes.
Am I audible?
Yes.
Okay, great. I wonder if I could have a light.
Yes.
I'm getting even older than I think. It's truly a great honor to introduce a true Gandhian of our times, Dr. Abhay Bang. Dr. Abhay and his wife, Dr. Rani, are known the world over for their exemplary work in providing community-based healthcare to one of the most underserved populations of our country. The voluntary organization which they started, SEARCH, the Society for Education, Action and Research in Community Health, has been working for 40 years in Gadchiroli in Maharashtra, not only in village healthcare, but also conducting research which has served as the basis for rethinking how to serve people, to meet their healthcare needs, and importantly, to influence health policy, such that these successful efforts can be multiplied. The models that they've developed have been internationally impactful in a variety of spheres, actually, ranging from the hidden burden of gynecological disease in rural women, the management of childhood pneumonia and newborn care delivery in resource-constrained conditions. This last model has so successfully reduced infant mortality rate that it was adopted at a national scale-up by the government of India. And the numbers of people whose lives have been impacted as a result are truly staggering. 800,000 Ashas delivering services and hope to 11 million rural neonates as of 2017. So in addition to working at the grassroots, where care is most needed, he's a scholar and a researcher whose work has been published in the most stringently reviewed and evaluated international journals, such as The Lancet, accounting for its very wide impact. He's also an inspiring author whose work in Marathi has received literary awards. His honors are many, and I will just mention a few. The Padma Shri by the Government of India, the Public Health Champion by the WHO, the Mahatma Gandhi Award for Humanitarian Service, the Global Health Hero of Time Magazine, a MacArthur Foundation International Award for Creative and Effective Institutions, the Save the Children US Award, and many, many more. And most recently, he and Dr. Rani were honored with the Gates Foundation Goalkeepers Champion Award for their work in driving progress in child survival worldwide. Dr. Abhay, thank you for the efforts of yourself, Dr. Rani, and your team in keeping alive the importance of the right of medical care to rural communities. Your dedication and service and work remind us all that it is possible to work with very large and seemingly intractable problems and to make an impact with courage and focus and determination. We're so sorry that Dr. Rani could not be with us for health reasons in person. We thank you both for being such an inspiration to us all and for accepting our invitation to deliver this lecture. Please.
Thank you, Dr. Dhawan. When I was in the 5th standard and living in Sevagram Ashram, in our house there was Mahatma Gandhi's large photograph. One day my father put 2 other photographs on the 2 sides of Gandhi's photograph. One photograph I could recognize because of flowing beard, Rabindranath Tagore. But other photograph of a man with a South Indian pagdi, I couldn't recognize. So I asked my father, who is he? And he told me that he is the greatest scientist of India, C.V. Raman. That was how I was first introduced. 65 years later, I am here in his institution. And thank you for inviting me to speak. Both Mahatma Gandhi and science are these 2 poles, and I am sort of hovering between these 2 poles, these 2 pollsters. So the topic, as I have titled, you can see. What I intend to do today, how does it move? Okay. I intend to tell you a story and then a journey of 3 research studies, and then would like to propose an alternative approach to looking at research and how some of Gandhi's ideas could be applied to the healthcare system or the vision of healthcare system in India. So the story begins at this place. Many of you would recognize this is Mahatma Gandhi's ashram in Sevagram, Bapukuti. In 1945, my father was released from jail. He was in jail in 1942 movement, and then new up to come Congress government decided to send this young economist. My father was professor of economics to the US for studying economics further. So all his admission, scholarship, everything was done. And a week before his scheduled departure, he went to see Mahatma Gandhi. Gandhiji was sitting in this Bapukuti. My father went inside. He was sitting, Bapu was sitting on a bamboo mat and writing something. So my father bowed to him, said, Bapu, I am released from jail and I am going to US for studying economics further. I want your blessings. So Gandhiji looked at him for a few seconds and then uttered only one sentence. He said, and he said in Hindi, so let me first say in Hindi, he said, अर्थशास्त्र सीखना है तो अमेरिका के बजाय भारत के देहातों में जाओ. Right outside this Bapukoti, my father tore away his admission papers, scholarship papers. And within a month, he found out a village next to Sevagram Ashram, village called Barbadi, and started living there, living like a farmer and studying and understanding economics by actually living like a farmer. I was born when my parents were living in that village, Barbadi. I studied in the school which was started by Mahatma Gandhi in this ashram itself. So my whole childhood was actually steeped in the surrounding which was Gandhi-maya. And so, at a very young age, somehow without understanding the gravity of what we were deciding, but my elder brother and I, at the age of 13, we decided that we will work for improving the agriculture in India and health in India. So he said, I'll improve agriculture, so I had no choice. By default then, I said, okay, I'll improve health of rural India. The tryst with the destiny that we made with each other, we lived up to that. And so nearly 40 years after that, when Rani and I came back from the US after studying public health there, Gandhi's words were still echoing in our ears. Go to the villages of India. And we were thinking as to which place we should work. And then something happened. I had gone to Delhi and was staying at Gandhi Peace Foundation, and I was introduced to an old man. He looked a little like Mahatma Gandhi. And I'll tell you why he looked like Mahatma Gandhi. So he asked me, "So Abhay, tum डॉक्टर हो?" हाँ जी. तो अमेरिका से पढ़ के आए हो? Yes. So tell me Indian definition of health. Nobody in my 10 years of medical education ever asked me or told me what is Indian definition of health. So I blurted out WHO definition. He said, no, that is Western definition. Tell me Indian definition. So I said, no, I don't know. So health को, healthy आदमी को हिंदी में क्या कहते हैं? स्वस्थ. That is the Indian definition of health. जो स्व में स्थित है वो स्वस्थ है. That was a eureka moment for me. I had looked at health through medical viewpoint, treating sickness, or even studying public health in the US. We had looked at health as some service, some commodity to be delivered to the needy people by the public health agencies or governments. And here was a new meaning. The word swasth, one who is autonomous, one who is free from dependence on others, he or she is swasth. So Indian definition of health, the word swasth, the concept of health is linked with autonomy and responsibility. This is a very empowering concept, because when you look at health as something dependent on doctors or hospitals, you are disempowered, you are dependent. But the word swasth reminds you that it is your freedom, it is your responsibility to live healthy. Extending this concept of swasth, of self-responsibility towards your own health, and applying it to Gandhi's concept of Gram Swaraj, I coined a new word for me as a goal of health, that is Arogya Swaraj. Health is not something to be delivered, but health is to be earned. Health is to be self-governed. And the new institution which Rani and I founded, called Search, we decided for us the vision. What do we want to do in the villages? We want to create some models of Arogya Swaraj, where villages can manage their own health. And that's how we went to Gadchiroli. A quick trip to Gadchiroli, the red area that you see, about 1,000 kilometers from Mumbai is this Gadchiroli, the least developed, poorest district of Maharashtra, covered with thick forest, 1,500 villages, remote, distant, poor connectivity, and primitive farming and collecting forest produce. These are the main occupations. When we went there in 1986, this was the prevalent mode of transport. Even sick children, sick women had to be transported by bullock carts, and intermittently you heard bomb blasts because of Naxalite movement. So everything, every problem which could exist, it existed in Gadchiroli. And that was interesting challenge. That's why we decided to go to Gadchiroli, where people didn't have health care, access to health care was poor, nobody else wanted to go to Gadchiroli. So there is a charm in going where nobody wants to go. And so the Gandhi's words, go to the villages of India, and so we chose Gadchiroli to go and work. This is our village now. We have established this village and we call it Shodhagram, a search village or research village, a village in search of health care for rural India. We have our hospital for tribal people, a research center, training center, and about 100 of our colleagues, we all live there, and from here we operate in surrounding villages. Now in the very third month of our stay there, a girl, a tribal girl was referred to me. I also have degree in medicine. So this girl was referred to me as suspected case of heart disease. I examined her and I felt that probably it was not heart disease. It probably was a sickle cell disease. And no case had ever been reported from Gadchiroli of sickle cell disease. So I had to establish the test from the very beginning, and she turned out to be sickle cell disease. In that excitement that I have found the first case in the district, and I'll like to remind you, I was just 34 at that time, fresh from the US, and so first case reporting, you have such an excitement, and in that excitement, this is sickle cell, how normal red cell, they become crescent shaped, that's why it's called sickle cell disease. We did a sample survey, took blood sample from 3,200 tribal people, and assessed how much was the prevalence of sickle cell there, and published those findings, shared. The minister of Maharashtra government came for that program, and he announced that this disease which we never knew about has been found in Gadchiroli. So we'll start a tribal medical research center in Gadchiroli. We were very delighted. This was published in the journal, this study. I received my first award for this work from Maharashtra government, but nothing happened to the Tribal Medical Research Center. Center was established, but it was established in Pune because researchers wanted to live in Pune. There were no tribals in Pune, but that didn't matter. Tribal Medical Research Center was started in Pune. So we went back to tribal leaders saying, look, this disease was found in you, but center has been shifted to Pune. So raise your voice, make some political demand. So they looked at us blankly. They said, doctor, did we ever tell you that sickle is our problem? You came and you said sickle is a problem. So it's your problem. We gave you a drop of blood. We thought young doctor couple has come. Why disappoint them? So we gave you a drop of blood. We have nothing more to do with this problem which you call sickle. You found it out. You solve it. That was a very rude shock. And my first learning in the field of research. We realized, why did it happen? The disease which we investigated with such curiosity and spent nearly 1 year of our life, tribal refused to acknowledge that problem because most of the sickle cases are benign cases, sickle cell trait, and so they didn't think that this was an important disease. We realized our mistake was, actually research should address the needs of the community I work with and not the research community I report to. Usually we all scientists will live in the mental world, peer group, scientists like us. And we are always thinking about research publications and research conferences and PPTs and lectures and claps that you would receive at the end of the lecture. And so we want to work on problems and publish something which will be appreciated, acknowledged by the peers. But if that research is not relevant to the people on whom you do the research, it falls on his face as our sickle cell disease research fell. And so we decided hereafter our research problem must be something which are priority for the people of Gadchiroli. So how do you come to know it? So Rani and I started going, sitting around night fire, talking with the tribal people as to what their problems were. And then we called what we, People's Health Assembly, in which representatives from 50 villages were invited. For 2 days, discussion went on, and then we asked them, by way of voting, identify your health priorities on which you want us search to work on. So through voting process, they identified these 6 problems. They said, ये हमारे problem है, आप कुछ कर सकते हैं तो इस पे करिए काम. Now some of the problems of course are well known, malaria and child death. But then white discharge among women, gynecological problem, never heard as a public health research priority. Alcohol, alcoholism, backache. But these have now become 30 years later, the global burden of disease study has identified backache and then alcohol and tobacco as the major problems. And so listening to people gave us 30 years ahead of the rest of the world research priorities to work on, and for the past 30 years we have done nothing else but to work on these priorities given to us by people. I'm going to take only one of these. And let me share with you how and what happened in search of how to reduce child mortality in Gadchiroli. So we established our population laboratory of 102 villages, population census, and every birth and every child death was recorded, and every child mortality was investigated as to what was the cause of death. At the end of the first year, we found that infant mortality rate was 121. Infant mortality rate is how child mortality is measured. If 1,000 live babies are born, how many die within 1 year? That's called infant mortality rate. It was 121, very high in Gadchiroli. And causes of death, pneumonia was cause number 1 and neonatal mortality was cause number 2. No, there were no doctors in villages. Even the IAS officer's son in Gadchiroli died of childhood pneumonia because there was no proper medical treatment. So what would happen to the children in villages in Gadchiroli? Now, child with pneumonia usually is gasping for air, oxygen. It's a very pathetic sight. Child becomes very miserable, and you can see here this one child with pneumonia with chest indrawing. Here you can see chest indrawing. So by counting respiratory rate of the child, you can get some rough gauge of presence or absence of pneumonia. And respiratory rate of 50 and 60. 60 for newborn babies and 50 for children more than 6 months old. If such condition exists, usually it is pneumonia in children. Now, how do you take diagnosis of pneumonia in children? Because people couldn't even count up to 60. And so I devised this simple equipment which I call breath counter. You can see 2 rows, one is for the neonate, another is for the infant. The upper row, let's take for neonates, it has got 6 beads. People could count up to 10. They had no wristwatches. So there is a sand timer here, 1 minute sand timer. When there is a child who looks sick, turn this upside down, sand starts flowing, and count breaths. For every 10 breaths, move a bead. For every 10 breaths, move a bead. People don't know how much it is. But if the red bead is moved before the sand is passed, it is pneumonia. I compared this with my own diagnosis using stethoscope on 50 children. Illiterate guys could diagnose pneumonia 82% correct. And we thought this was good enough. And we conducted a field trial of management of childhood pneumonia in villages by community health workers and illiterate guys. Diagnosing in such a simple way, and then treating with oral antibiotic co-triamoxole. And you can see case fatality from 13.5% case fatality in children without treatment in villages before we introduced the treatment, and with treatment it came down to 0.8%. And 35 years later, even though study was completed, we continued this as our moral responsibility as a service program. For the past 35 years, pneumonia mortality in treated children in Gadchiroli has remained 0.5%, 0.5%. This study, because it was a controlled field trial in 102 villages, it could be published in the Lancet. Lancet published it as the first study in the world which showed that pneumonia mortality in villages in developing countries could be reduced. And IMR from 121 came down to 76. Great. After this Lancet study, subsequently when the global ARI program, as it is called, Acute Respiratory Infection Control Program, was designed, the Gadchiroli field trial and this case management approach became one of the major strategy to reduce pneumonia mortality world over. Now the remaining problem was mainly amongst the neonates. And rural neonates are taken care of at home. At that time, in Gadchiroli, 95% deliveries used to occur at home. And a delivery room is a dark room which is of no other use, no ventilation, no light. And that woman, once you start getting labor pain, she goes there. And one old woman, maybe grandmother or mother-in-law or a dai, they go there. After few hours, news comes out whether there is a baby or not, and the mother and baby are not allowed to come out for 10 days. At the end of 10 days, if the baby survives, mother comes out with a live baby, and if the baby is dead, it is buried in the same room. And look, 60% of rural India was born in this kind of rooms and this kind of neonatal care practices. And not surprisingly, the neonatal mortality rate was something like 60, 70. 1,000 babies born, out of them 60 to 70 used to die within first 1 month neonatal period itself. That was the major challenge, and globally 5 million neonatal deaths used to occur every year. In India, 1.5 million neonatal deaths annually, and 26 million births which occur every year in India. So how to provide neonatal health care to these? Hospitals were too far, not very accessible, costly. The nearest neonatal care unit to Gadchiroli was 200 kilometers away in Nagpur. And these babies and these postpartum mothers were not allowed to even step out of that delivery room. Forget about hospitals some kilometers away. So neonatal care has to go where the babies were. Hospitals, theoretically, yes, and so we thought of turning this upside down. WHO, UNICEF guidelines were that if the neonate is sick, must be immediately hospitalized. But where were the hospital? And so, in one moment of a eureka moment, I thought about this home-based neonatal care model. If neonates cannot go to hospital, hospital science must go to the homes. And so this model, where the goal is to reduce neonatal mortality by developing a very simplified primary care neonatal model delivered by the women in villages itself. Now, how do we know it works? So we conducted a controlled field trial with, you can see, with 39 villages as intervention villages where home-based newborn care will be introduced, and 47 government program area villages as control villages where regular government programs continued. Collected baseline data for 2 years in both the areas, and then introduced intervention for 3 years in these 39 villages. When the baseline information was collected, the baseline infant mortality rate was 76 and the neonatal mortality rate rate. First month deaths, 60. Now, for delivering this home-based newborn care at the doorstep, you naturally need a woman. Experienced, wise woman who will be willing to go to every home and hut, day in, day out, any time. And so, she is Kajubai. Kajubai is a Dalit woman from a village called Ambeshivani, 7th standard fail, husband was alcoholic. So from her village, we selected her to become the village health worker. We call them Arogya Doot. So 39 such women were selected from 39 villages. One woman per village to become a community health worker through a training program of 36 days, spread over 1 year period. And while continue to work in their own village, we trained them to become a village level neonatologist. They were trained to make home visits, take the history of the baby and mother, weigh the baby, measure the temperature, record all the findings, and give health education to mother. Here they are learning if the baby doesn't breathe at birth, which is called birth asphyxia, how to resuscitate this baby following the same algorithm which is observed by pediatricians in the delivery room. And if babies were preterm, low birth weight, becoming cold, hypothermic, how to keep them warm at home. So this kind of sleeping bags for babies. And if babies develop signs, symptoms of sepsis, neonatal sepsis, which is a very difficult condition to diagnose, even in the US, studies published from the Boston, which is Mecca of neonatology for the entire world, studies published from the Boston show that when American neonatologists diagnose a case of neonatal sepsis and treat it, but the culture subsequently show that their diagnosis was correct only 5% cases. 95% it is wrong. But to save the baby, antibiotics were still given. They are still given world over. So we designed a simple clinical algorithm by which these village women, our Arogya Doot, could also diagnose neonatal sepsis and treat with antibiotic, oral as well as injectable. Now look at the impact. Impact was measured in terms of change in the neonatal mortality rate. Now this is for the year 1993 to 95, the baseline, and NMR for two areas was around 60. Now the yellow area is the control area, government program area. And you can see this for the next 10 years, except for this 1 year of random fluctuation, the NMR has remained at 60 or above. And that represents in a way whole of rural India. For 10 years, rural NMR remained almost same throughout India, no change. And the intervention 39 villages, at the baseline it was 62, and within 3 years it came down to 26. 62% reduction as compared to the control area. From here, the research phase was over and we continued this as a service program. It is still continued. And the NMR in the intervention area then became 70% less as compared to the control area. And if we bring these two impacts together, the first phase of pneumonia management in children and then neonatal mortality, you can see this is infant mortality rate. To begin with, it was 121. With pneumonia treatment approach, it came down to around 80. With home-based newborn care, it reduced and reduced and reduced and came down to the level of 30. This is when Government of India decided the national goal of India to reduce infant mortality rate to the level of 30 in 2003, the national health policy. In these 39 villages in India had already achieved it. So, Gadchiroli remained same, poor, remote, inaccessible. But by introducing two simple interventions and by transferring power of managing illnesses to the community itself, the IMR reduced from 121 to 30. And who did this remarkable change? These 4 women. Now look at them. What is different about them? The fact is that there is nothing different about them. They are as ordinary as crores of rural women in India or world over. Dai, grandmother, mother and Arogya Doot. But you train them, give scientific tools in their hands, and then they can do this miracle. And why only in Gadchiroli? Because such women exist everywhere in the world. So they can do it anywhere. And what does it require? It is same Kajubai 20 years later, her photograph. So these are the simple equipment she needs. This is the baby's weighing scale, this is wristwatch, this is antibiotic, this is ambu bag for giving breathing if the baby doesn't breathe, thermometer. Equipments which costed 1500 rupees at that time. And the Kajubai with those equipments in her shoulder bag, and with knowledge in her head, skills in her hands, and compassion in her heart, she could become a mobile neonatal care hospital. She could turn any home delivery room and rural home or hut into a mobile neonatal care unit. And I am not exaggerating, because the case fatality rates of home-based newborn care for various birth fates was similar to the secondary level, 13 secondary level hospitals selected by National Neonatology Forum. So the results really exactly matched birth fate by birth fate with the results of the hospital mortality. So good quality newborn care could be provided at home by making Kajubai and women like Kajubai, empowering them. That's why this is the logo of home-based newborn care. That hut was dark and that woman was alone there to take care of her baby, but open that one window of knowledge, window of opportunity, and same rural women become empowered and they can take care of family's health and baby at her bosom. So this is essentially empowering women, empowering communities to take care of their own health, Arogya Swaraj. And proven scientifically that it works. This study was published in the Lancet in 1999, but subsequently Lancet historian and Lancet editor, they selected what they thought were the milestone papers published in 180 years history of the Lancet. And if you skim this volume, you have papers of Louis Pasteur, you have paper of Benting and Best, insulin discovery, Alexander Fleming, paper on penicillin, and Ronald Ross, discovery of mosquito transmitting malaria. And when you come to 90s, there is one paper from obscure place called Gadchiroli, home-based newborn care. So this became world's first study to demonstrate that it was possible to reduce neonatal mortality in villages at a very low cost with simple measures, nothing but taking science to where it was needed and giving in the hands of the people whose problem it was. Government of India asked Indian Council of Medical Research to replicate this in 5 states. It was replicated. Again, it was found that it worked in every state where it was replicated. So finally, in 2011, it was accepted as a part of 10th 5-year plan as the main strategy to reduce child mortality in India. Operational guidelines were published by the Health Ministry, and we were asked to train at that time 8 lakh and now 10 lakh ASHAs, community health workers, to provide home-based newborn care. So we developed a 3-tier training system from national level to district level, and 10 lakh ASHAs were trained to deliver home-based newborn care. And last year, 15 million rural neonates received home-based newborn care at their home. Every year, about 1.5 crore rural neonates are now receiving this care. It's now also used in Bangladesh, in Nepal, in Pakistan, in countries in Africa, in Bolivia. Nearly 80 countries use now this principle of providing better care to neonate at home. 2-3 years ago, when the Prime Minister in his Man Ki Baat program, once he had a dialogue with Ashas all over India. And when he was talking, the Ashas from Jharkhand told him a story that how a baby was born, baby didn't breathe, and we saved the baby, and that Asha was one which we had personally trained by search. It was mere coincidence. But so the stories of newborn babies being saved by Ashas, they became story in every village in India. And our team went to a village in UP to see how the program was going. So that woman, Asha, they said, Sahab, aapne to hamari zindagi badal di. Kya ho gaya? So she said, earlier nobody in my village knew me by name. As a child, I was somebody's daughter, my father's daughter. Then I was married, I was somebody's wife. And then I am somebody's mother. I am always somebody of a man or of a child. But I was nobody. Nobody in the village knew me by name. Now the whole village knows me by name. I am born. It was such a moving statement that 1 million Ashas saying that now we are an entity. So home-based newborn care has not only saved babies, but they have also empowered village women who became village health care provider. Subsequently, WHO, UNICEF, USAID, Save the Children, they had this global declaration that if hospital access is not possible, home-based newborn care should be provided to neonates in developing countries. This was about child mortality. And the first series of problems which people told us, now disease profile is changing and non-communicable diseases are gradually becoming more and more important. But with the same approach, one which we employed earlier, we are continuing to use the same approach. How can we empower people in village to manage their whole health care? So this approach continues. Now, from sickle cell disease to home-based newborn care and subsequent NCD, what we went through, I'm sure most of the young researchers also go through. When they complete their whatever it is, MDs or PhD or anything, where should I conduct my research? And that's a very crucial stage, because a young scientist is going to decide his future career, which will be his Kurukshetra. My answer would be, go where the problems are and not where you are a problem. People usually choose places with facilities because there are facilities. But then there is no problem to be solved there. Facilities are full of facilities. And to maintain the facility is the problem. There is no other external societal problem to be solved. So why go where you are a problem? Better go where there is a problem and nobody wants to go and you become the pioneer. It's very easy to become pioneer, I can tell you. You only have to go where the problem exists and where nobody else goes. What did happen to Newton? Newton went and sat under that apple tree. One simple act. And then we all know what happened. But then for that, he had to go out of his house and sit under the apple tree. Such apples are falling every day in villages. Somebody with scientific training and mind only has to go and witness and watch and observe. And you have number of problems to be solved. You don't have to flip journals to see what my next research should be on. Problems are waiting to be solved. So go where the problems are and not where the facilities are. Then how should I identify the problem? Listen to people. That People's Health Assembly gave us problems 30 years ahead of the global public health community. When I presented home-based newborn care at the WHO headquarters in Geneva in 1999, So the head of the maternal child health, while taking dinner, he asked me, Dr. Bang, how come you are able to see a problem 10 years ahead of us? I didn't share that story, but as Dr. Dhawan mentioned, our one of the first research was to show that gynecological problem of women was a major public health problem in villages. After that, WHO made that as a priority. So this had happened. Then we developed program on childhood pneumonia, then WHO incorporated it. So newborn care was the third time. So it was very legitimate question, genuine question really. Then how come you are able to identify a problem and develop solution 10 years ahead of us? So I said, look, I can't claim that we are more intelligent than you. You are the cream of the world at the WHO headquarters. But only advantage we have is we are 10 years nearer to community than you are. And that makes all the difference. And so, listen to the people. People can give you remarkable research problem because these are their problems. They are burning problem. Only thing that we don't come to know of it. Listen to the people, observe, and scientific data. In our case, epidemiologic data. In somebody else's case, it could be different data, but this is how you identify the problem. How should I conduct my research? Now, this is a very major question because how you conduct research, who conducts research, and who owns the research has become a major issue. It's not merely an academic issue, but currently the knowledge is the new wealth. It's a new powerhouse of wealth. So research decides where the wealth will go. So who conducts research is practically a question of where the money or wealth of the world will go. There is another ethical issue also here. Researcher gets publication, researcher gets grant, researcher gets career growth. What do people get? People on whom we conduct research, people like us in the field of community health, or other scientists who are funded by money paid by research, paid by the people. What do people get out of my research? And so, in case of sickle, I have a great regret that we conducted that research on people because people got nothing finally. I got my award, we got publication, we got recognition, people got nothing. And so, can there be research approach by which people are also enriched, empowered? The research, I have designed this 4-stage model. Research on the people, what we did in case of sickle cell disease. I feel guilty, embarrassed of that particular research, but we have done it. So I have to admit that that was research on the people. So research on the people, research for the people, research with the people, and it's my dream that a day would come research by the people. With more and more knowledge, literacy, education, and computer sciences, and artificial intelligence, every human being should be able to do research. And why not? Problems are faced by every human being. Why should research be monopoly only of us scientists? But then, it's futuristic, but research with the people is something which can be practiced. Research with the people will have, people should need it, its characteristic would be, people should need it, people should understand it, people should participate in doing it, Kaju Bhais and the thousands of mothers who participated in home-based newborn care, people should use it, and finally, people should own it. It should permanently become wealth of the people. That skill, that ability to manage problems should become their own. So even if researcher vanishes, still that solution remains with the people. Now, will such approach produce impact? You can legitimately ask the question. We all know that story when the king, the Archimedes said to the king that give me a liver long enough and I can move the earth, the principle of liver. So, this research with the people approach is that lever. Their research doesn't stop only in research journals. It changes the policy. It changes the practice. It reaches out to the millions of people. From Gadchiroli to global. Research happens in Gadchiroli, but policies are changed in New Delhi and London and Geneva and New York. That is the power of science going to the people. It's not power of Abhay Bang or search. There is nothing unique about us. What we have only done is taken science where the problems existed and given the power of science in the hands of people whose problems it is. So the research with the people is that lever which can change the world and shape global policies. Now finally, I want to do some reflection on how can this apply. The idea of Arogya Swaraj, people's health in people's hands. Not only skills and resources and knowledge, but also responsibility. Because when it comes to non-communicable diseases, the most of the responsibility of maintaining your own health is in the hands of the individuals. You cannot outsource it to somebody else, nor to doctor, nor to hospital, not to the medical insurance companies, nor to some prime minister's program or scheme. Ultimately, if you develop heart disease, you develop heart disease. It's your fate, your destiny. So you shape your own destiny. So how can this be applied? Now today it has become very risky to fall sick. Major illnesses are non-communicable disease, heart attack, cancer, stroke. Most of these require very high technology solutions, very high cost. And technology goes on developing, and unlimited technological possibilities mean astronomical cost. You either die or you go bankrupt. That is the dilemma which any ordinary citizen faces when somebody in the family develops serious illness. If you don't seek medical care, you die. If you seek medical care, you become bankrupt. In the US, in the last 15 days of every human being's 15 days before death are usually spent in ICU on ventilator. And that sucks out 1/4 of lifetime saving of those individuals. So medical care has become a very risky financial as well as biological venture. US medical care costs, the knowledge, the model which we are trying to imitate in India is the US model of healthcare. Though not entirely, but partly, especially on the technological side. A new discovery or new drug comes in the US, within 15 days it is available in Mumbai. Only thing, the cost is very astronomical. But US medical care cost is $10,000 per capita per year, not per patient. Average cost for the entire population. And 18% GDP of the US, look, it is the US GDP, not India's GDP, but the US GDP, 18% is spent on healthcare. And McKinsey has made prediction, future projection, that by 2050, if the same cost escalation continues, US will be spending 37% of its GDP on healthcare, and by 2097, you won't believe, but by 2097, US will be spending 97% of its GDP on healthcare. Not possible, but just theoretical modeling. So the US medical care cost, that model is just impossibility for India. The medical care models from the West are wasteful, too costly, too late. Come at the terminal stage of the disease when disease has already struck you, hit you. And they are impossible to sustain financially. Even US finds it difficult to sustain financially. What about India, if we copy? According to World Bank, our per capita health expenditure in India is $57 per capita per year. And US is $10,000 per capita per year. How can you imitate a US model of medical care? We need something different. 6 crore people sleep in India below poverty line every year due to cost of medical care. Again, World Bank study. So Indian people are unable to sustain the medical care cost of the current model, and so the challenge of healthcare in India is that all of us have to face it, is how to provide accessible and affordable healthcare to 1.4 billion people living in nearly 1 million villages, hamlets, towns, slums. Huge population, impoverished, semi-literate and scattered. These are not few cities. These are nearly 1 million locations. How do we provide health care to such people? The best way of providing universal health care to 1.4 billion population is not to open the AIMS or tertiary care hospitals or even medical insurance schemes, because these are for the terminal illnesses, lateral illnesses. The best way of providing health care to 1.4 billion people is to generate universal capacity to care for health. Every individual, every community, every village should have capacity to take care of 80-90% of their own health problems, either prevent health problems or take care of health problems. This is how we are attempting by way of Gadchiroli search model of healthcare, of which I shared a small part with you only in relation to child mortality. But this is how we are trying to evolve a model which hopefully will be more relevant and more accessible and effective for the healthcare needed for India. That would be Arogya Swaraj. When people take care of their own health, we found in Gadchiroli that 41% men drink alcohol and 44% of population, including women and children, consume tobacco products. This was by way of a district sample survey that we conducted. And people spent together on alcohol and tobacco, people spent 393 crore rupees per year out-of-pocket expenditure on tobacco and alcohol, when the district development plan in Maharashtra, every district has its own annual development and welfare program plan, was 156 crore rupees. People were spending twice the amount on purchasing alcohol and tobacco. Now, unless alcohol and tobacco is reduced, the two main risk factors for non-communicable disease in India, for hypertension, for heart attack, for stroke and for cancer and for addiction, you cannot provide only hospital-based de-addiction services, futile. Success rate 10%. Through a population-based approach for the entire district, we have reduced tobacco and alcohol in the last 8 years by 30%. Not very dramatic. This is more difficult than reducing child mortality. But the entire population reducing alcohol and tobacco consumption by 30%. This is the first and the only such pilot study in India. People's health in people's hand. To consume tobacco or alcohol or not to consume tobacco or alcohol. Should we permit alcohol and tobacco sale in our village? Villages are deciding. As a part of Panchayat Raj, villages are deciding, and 700 villages have completely banned alcohol in their villages. 90,000 men have quit consuming alcohol. 1,60,000 individuals, women, men all together have stopped consuming tobacco, and so the population prevalence has come down by nearly 30%. People's health in people's hands. So Arogya Swaraj is the model when people should be able to take care of their own decisions, life decisions, lifestyle decisions, either individually or collectively as the community, and if when they fall sick, most of the sicknesses can be managed by empowering somebody in the village, the community healthcare model, and this would be Arogya Swaraj. Gandhi very interestingly says at one place that Swaraj, usually we all mean or people understood at that time, Swaraj hoga to kya hoga? Hamara Raj hoga. People understood Swaraj as rule of self. Whatever I want, I should be able to do. So he says that Swaraj is not the rule of self, but it is the rule on self. I should be able to decide my behaviors responsibly, so that I should be able to only accept healthful behaviors and decline unhealthy or those behaviors with bad consequences. So Arogya Swaraj is people's health in people's own hand. So not the Medicare or Medicaid or healthcare models of the West, not the medical insurance alone. Medical insurance is a good thing, not a bad thing, but medical insurance has its own limitations, which I won't get into. But for providing health and healthcare to 1.4 billion people, the Gandhian path of healthcare would be Swastha. Yes, I forgot to tell you. I said that that old man looked like little Mahatma Gandhi. He was the very grandson of Mahatma Gandhi. Professor Ramchandra Gandhi, who was earlier professor at the Shantiniketan, and then he had retired and come to Delhi, and he gave me this insight of, so actually all my ideas and inspiration come from Mahatma Gandhi. So I am very happy that on 2nd October, this research institute, in the name and founded by Professor Raman, you invited me to share our ideas, our experiments on trying to develop healthcare inspired by and consistent with the ideas of Mahatma Gandhi. Thank you so much.
I'm sure there are many questions after this wonderful talk.
Can you give me a glass of water, please? Then I can take questions. Oh, it's here, it's here. Thank you, thank you.
Thank you very much for that excellent talk. Clearly, you have saved, through your direct efforts, hundreds of thousands, if not millions of lives. Now, you mentioned the runaway explosion in healthcare costs in the United States and the GDP, percentage of GDP that they spend. The Indian government spends about 1% or less of GDP directly on healthcare. Rest of it is borne by citizens directly, either through insurance or through out-of-pocket expenditures. Now, while what you're doing is irreplaceable and needs to be done, by these kinds of interventions, are we letting the government off the hook? Because clearly they should be spending for a country with our economic status somewhere around 6 to 7% at the very least of GDP. And if they are spending 1/6 of that, and they do this supply-driven band-aid like these schemes they have for tertiary healthcare, do you feel that there is a problem that when we provide the kinds of interventions that you provide, the government says, okay, it's happening, let's leave it to them, let's leave it to these charitable institutions, good people with good hearts to manage healthcare, the government will do nothing about it?
Look, in case of health, we can't divide scenario as to we versus the government. We are the government and government is us. Though we know that state is different, state power is different, it has its responsibility. But I would not like to divide responsibilities that my healthcare is government's responsibility. So I live recklessly. It's government's job to take care of my health. That will be extremely dependence producing model. And finally, what will government do? It will issue a death certificate. So finally, one who will die will be I. So health is my wealth. So health is also my responsibility. Health is also product of my how do I live. I am not absolving government from its duty. But government policies should be more and more such so that people can take care of their own health. For example, Government has to restrict tobacco access. Government cannot say let people consume, let people make the choice. So governments definitely have some regulatory roles. Government also has got roles like ASHA program. Ultimately, finally, it's a government program. Home-based newborn care is entirely funded by government now. 250 rupees per neonate that the ASHA provides service, government gives the fund. So I don't look at it as if absolving government from the responsibility. Because people have to share the main burden of illness. So they should also have the power of avoiding the illness or finding the solution within their accessible area. A village, yes, people can easily access healthcare in the village. But if you ask me to go to AIMS in Nagpur, a villager will not be able to go. So we don't need to construct or design models assuming that as if we against government. It's not absolving government, but it is owning the responsibility by us, by community, sharing the responsibility, sharing the health knowledge power with the community whose health it is. But at the same time, government has the responsibility of designing healthcare model in such a way that more and more power, resources, they flow to the people rather than to the tertiary care institutions. If swastha means being not dependent on others, in that others I'll also include government, because when I fall sick, government doesn't come running. I have to manage my own illness. वो मेडिकल इंश्योरेंस तो बाद में कैश reimbursement होगा तब होगा. But I have to manage my immediate health. So health is, in ultimate analysis, health becomes something which every individual has to be responsible for. There is no point in saying that my health is government's responsibility. It is, in some sense, it is. As a public good, it is government responsibility, and we should not be absolving government from that. But government should be designing models such which are not more and more very costly, which are tertiary care dependent, but should be designing healthcare models which go to the grassroots and empower the people, empowering the people directly.
There is a saying I heard, be your own doctor. How much, in your experience, paying attention to one's health, attending or noticing small things and taking care of them, how far does it go in terms of taking care of one's health in the long term?
Let's make a distinction between our lifestyle practices and behaviors, and they, to a large extent, they decide our sicknesses, though not entirely. Sometimes I may develop COVID when there is a pandemic and it's not my lifestyle practice. But to a large extent, my living practices, how do I live? What do I eat? Do I do exercise? Do I have mental stress? Do I consume tobacco, alcohol? Do I live in a very polluted city? All these determinants decide the outcome. So let's not look at it, if I fall sick, how much of self-treatment I should be doing. But my behaviors, they decide to a large extent my health. So first thing, my behaviors are in my hands. For that, of course, I should receive the correct knowledge as to which behaviors. People of Gadchiroli don't know that tobacco and tobacco products cause cancer or stroke or heart attack. So, but if I fall sick, if somebody in India falls sick, I won't say that he should be necessarily treating himself always.
No, I didn't mean treating one's health.
Yeah.
Paying attention to one's health.
Yes, but attention to health to a large extent is individual community issue, and we can't be. Russia had developed this model in 30s and 40s and 50s, and they had a community health worker. If I remember, they used to be called health share or something. But they developed schemes that every laborer will be able to go for 15 days to a holiday home where he'll have sauna, etc. But then rest 360 days he was consuming so much of vodka that Russia's infant mortality rate started increasing and Russia's adult life expectancy started decreasing. So you can't just provide some medical care and expect problem to be solved.
So I have a, thanks for your presentation. I have a question regarding your initial phase of your work before government adopted this particular great model. I wanted to especially want you to focus on the economics of that initial phase, because when you create Arogya Doots, you need to compensate them. Of course, some motivation will be there to serve their own community in the village, but how did you manage the economics of it in the initial phase before government, woke up and adopted this model?
Look, we had designed this based on the observations in the Gadchiroli and the need, as data showed us, that neonatal mortality was the main cause of child mortality. We designed this and turned it into a scientific field trial. And we got funds for scientific field trial from MacArthur Foundation at that time, an international organization. So initially it was done as research funded by a funding agency, research funding agency. And so all the costs, including incentive money and compensation to Arogya Doot, drug costs, supervision, quality, training, etc., they all came from that. Once it was successful, published in scientific journals, later on, of course, you saw the story. Now, currently, government is funding most of its cost. But the one beauty of this approach is, we have compared, in 2000, year 2000, we have taken WHO estimated cost of saving 1 year of life, as it's a unit called daily disability adjusted life years. So different popular public health interventions, how much it costs to save 1 year of life. So the very popular and universal feeding program, ICDS, it costs $8,000 for 1 year of saving life. And this is dollar cost in year 2000, so today it might be $20,000. So on and so forth. Oral rehydration, $193 per life year saved. Home-based newborn care, $7 per life year saved. Because when you save a neonate, you save nearly 60 years of life. And at a very low cost.
Thank you, sir, for your wonderful talk. So I think for this program to work, we need motivated workers. So how do you sort of motivate them to work in this type of programs? Because I think otherwise people will tend to take it and then forget about it.
Look, we need two kinds of workers. One type is those Arogya Doots and their field supervisors. They come locally. We select them from the local villages. We give them training. And then, of course, we also pay them incentive money for working. We once asked them, of the various things that you get from us, rank them. And do you know, money came as the fourth. Before that came, I forget all four, but before that came the status and the recognition and that I get in my village. And you will be surprised. Do you know what was the first rank? They said, we got new knowledge. It was such an enlightenment. Even those rural women whom we consider ordinary laborers, etc., new knowledge is for them as if a new light in that hut. So they ranked new knowledge and skill and power. That was number one motivation. As ranked by them. And the second kind of workers which we need, I shouldn't call them workers, but I would like to call them colleagues, are the new scientific researchers. I am now 75, so I am not going to last long. But there are so many problems to be solved and so many opportunities to be solved. But young scientists, young doctors, young public health researchers, they usually don't want to go where the problems are. They want to go where there are institutions, national institutions, money, grants, air-conditioned room. Problem is that there is no problem to be solved. So for that, apart from, look, Mahatma Gandhi once when he was asked, he said, be the change yourself. So one thing you can do is whatever you want other people to do, you want them to do it yourself. So this is what we are doing in Gadchiroli, with the hope that young doctors, new researchers will feel motivated that yes, this is doable. But we have also started another initiative called Nirman, in which young graduates from all over India, 200 young graduates every year, they are selected, they come to Gadchiroli, and through 1 week workshop, 3 times a year, we try to give them this insight as that money is not the only thing that you need in life. Rather than moneyful life, explore a meaningful life. Money is required. Nobody would say that money is not required. But the purpose, a meaning to life comes from connecting yourself with the problem of others. And through Nirman, and Nirman has a very good acceptance in India. Out of those 200 young people we get every year, 1/3 are doctors, 1/3 are engineers, including IITians and people from the all India AIMS. And then, so many of them, not all, but about 30% of them then have eventually turned to social causes and social issues.
I have a question. It was very heartening to see how the Arogya Swaraj program is working in villages. But it's also true that a large number of young village people try to migrate to large cities. And our cities have a huge population of marginalized people. Is Arogya Swaraj also working with them, or are there other programs that exist?
If I do that, my friend here would say you have let the government off everything. No, I have left that to the government to develop livelihood programs. No, we do not have livelihood development programs or employment generation program, except for that ASHA program has generated 1 million employments, but that was not the original intention to generate employment. It did eventually, but that's not something which we have taken up a problem to be solved. Not that problem doesn't exist, it's one of the highest priority problem, but I don't think we have the ability. So one must restrict oneself to the scope of your work can only be what you can do. We have a little understanding in the field of health, so we have limited ourselves. We, at the most I can say, we are trying to keep young people healthy in villages so that eventually they can work somewhere.
Thank you for a very enlightening talk. I think you mentioned that the Indian healthcare system is based on the US model. I was wondering, is there any thought which went behind why an US model and not, for example, a UK or Australian model where there is more participation by?
Well, it's a very important question, that why didn't government have, in 2010, Government of India appointed a committee which they call High Level Expert Group. I was one member of that committee, and we were given the task of developing healthcare plan for India. Through 2 years' work, we did produce that report, which is called Universal Healthcare HLEG report. And at that time, it was Manmohan Singh government. So there was a lot of political pressure from Sonia Gandhi and the National Advisory Council to incorporate that model. But the economic thinking went against it, that should government take up the whole responsibility, can it take up the whole responsibility, and whether right or wrong, but Government of India decided not to take up that kind of huge responsibility of national health services as it exists in the UK. And in that sense, I said that we are following US model. Though government plays little more role in India, it's not as irresponsible as it is in the US. Government plays more role, but still about 2/3 of the cost of healthcare is paid by out-of-pocket expenses. So as my friend was saying, the government, currently Government of India, its expenditure on health, they claim it is more than 2%, but that is only jugglery. They have included water supply expenditure and food expenditure of ICDS and lumped it as health expenditure, which earlier it was not. But this is a recent innovation by Government of India, and that, by that they show that they are spending more than 2% on health. But actually, the original healthcare cost, the health system cost, Government of India spends 1% or 1.2%, state government spends something. So total expenditure 5% of GDP, equivalent of GDP, is paid per capita per year, out of which 3% is paid by private citizens out of pocket and 2% by central and state government.
I have a quick question, yeah. So, excuse me, thank you for that wonderful talk and the wonderful work that you do. So my question was about neonatal vaccination. I was just wondering how the coverage of neonatal vaccination is around the country, in villages and, under the Arogya Swaraj program.
No, Arogya Swaraj is not a national program, so I cannot be saying neonatal care vaccine. And do you know the best place to find answer to your question? Google. No, I don't know really. Neonates are not much vaccinated except for BCG vaccine given in the first week. Otherwise, vaccines are given to the pregnant woman. And then vaccines are given usually after 6 weeks. Neonates receive very few vaccines, mostly the BCG.
Doctor, I couldn't help but notice when you were showing the Indian map and the spread of the ASHA workers, the southern part of the country, there was a near absence of ASHA penetration. Is there a reason for that?
No, actually it is home-based newborn care being implemented through ASHA, that map shows. So you would find that Tamil Nadu and Kerala are excluded from that because the Tamil Nadu and Kerala IMR was already around 30 or less than 30. What home-based newborn care in Gadchiroli did was to reduce the IMR to the level of 30. But where that goal is already achieved, there was not much point. So Tamil Nadu and Kerala healthcare situation was much better, and so to my knowledge, home-based newborn care through ASHA was not implemented in Tamil Nadu and Kerala.
Is there a reason why those two states fare better than the rest of the country?
There are several, of course. Are you from Tamil Nadu or Kerala?
Yes, I am from.
You want to hear praise of those two states?
Not because of that. I'm curious. Why is it that?
Look, there are several reasons. Apart from education becoming more universal in these two states, women having much better status. You have to go to Bihar and UP and Rajasthan to see how women are treated there. That's why that Asha from UP said, "You have given me birth. I had no name in this village." So that's how women in North India are treated. In that comparison, women in South India, my wife is a South Indian woman, and women are treated much better. Third is that we must give credit to some populist politician in southern India, good or bad, but they adopted a lot of social welfare programs. So Tamil Nadu nutrition feeding program, nutrition program. There are several such social food program, health program, universal education programs which were adopted first by Tamil Nadu and Kerala, and then they became national model. So these two states have been pioneers. But there is a bad side of it. That bad side is that not only these two states reduced child mortality first, birth rate became the lowest here first, but non-communicable disease epidemic is also spreading from these two states. So diabetes, hypertension, obesity, stroke, heart attack, cancer, all these 6 diseases, their high prevalence has started from Tamil Nadu and Kerala, and then it is now gradually spreading to North India. So in a way, these two states are, I wouldn't call them now undeveloped countries, but they are like semi-developed countries.
Good evening, sir. Thank you so much for that very enlightening and inspiring talk. My question is, given that in view of the remarkably short period of time, about 5 years from initiating your research to achieving those remarkable success rates, what did you find as the largest challenge that you had to overcome in the IMR and neonatal?
The first challenge is, and which we learned through sickle, is here. We have these brain blocks that we as doctors or we as scientists, we know everything. Now this knowledge has to be delivered to these rural stupid idiots. That's how usually our approach is. And so we conducted research on the people. That brain block and getting over that arrogance of educated person and realizing that people have every right to decide as to what their health priorities are. Who is the planning commission to sit in Delhi and decide their health priorities? And look how wisely they selected those 6 health priorities ahead of what WHO selected. Now global burden of disease study and world public health community after 30 years is saying that these are priorities. So the most important challenge is overcoming our own professional egos and barriers that we create. Second is, I have found that when I write a good protocol, it works. When I work intuitively, I fail. Because no intervention program, unless you really have a very good sound written protocol, research doesn't work. So my second barrier is, or challenge is, sometimes I am in hurry. And I think the problem is too simple. Why should I write a protocol, etc.? Let me get into action. But I invariably fail when I do that. So both the challenges lie in me. Now if you ask me external challenges, yes, there are problems like people do not know several things which are known to science. Do you know when people identified malaria as their priority? So we suggested to them that indoor residual spraying with insecticide, which is a national program, so they should get it sprayed. They said, we are talking about malaria, and why are you asking us to spray the house? So we said, it kills mosquitoes. So what mosquitoes have to do about malaria? This was in year 1996. So nearly 90 years after Ronald Ross discovered that connection in Sikandarabad, Gadchiroli, which is hardly 350 kilometers away, but for 90 years that information didn't cross that distance. So lack of information. People are reasonable. People are not foolish. They are reasonable, but you have to reason with them in a language which they understand. The fourth important challenge is getting good, competent colleagues to work with you. Young professionals do not want to go where they are needed. But thanks to Trump, probably they'll now come back to India. And they'll be forced to work here. And I would say that money and the finance is the least of the problems.
Thank you very much, sir. I think we should observe every day of the year as Gandhi Jayanti. Because on Gandhi Jayanti, the whole country observes a prohibition. In other words, what I am trying to say is, like Gujarat, should the entire nation enforce Gandhi prohibition? Because since you mentioned alcohol as one of the problems, that is my question.
It's a difficult question. In the sense, these kind of widespread practices and of course addictions, you cannot get rid of by way of band, prohibition or mere legal restriction. For example, child marriage is banned, dowry is banned, corruption is banned, rape is banned. Yet, yes, I am not against, you should put legal restrictions. First, begin by stopping the advertisement, begin by stopping the promotive practices. Did you see the final match of Asia Cup? Many of you must have seen. Now the Asia Cup matches, this time there was something very interesting. The screen on which out or not out, that decision, when review is taken, entire stadium and why stadium, everybody watching the television is very intently observing there, and the big screen is shown, in which the third umpire gives the decision whether out or not out. Now when 1 billion people are focusing on that screen which is visible, there you could on either side see advertisement of Royal Stag. So 1 billion people were educated every day in the Asia Cup that drinking alcohol is the current in thing. So we must start from changing the ideas. The current knowledge is, and this is not Abhay Bang speaking, this is Global Burden of Disease Study speaking, that of all the causes of death, disease and disability causing in today's world, the top 7 causes, out of those top 7 causes, alcohol and tobacco are the 2 causes. So if we want to preserve health, alcohol and tobacco has to be reduced. Is the prohibition based way? Well, there are yes and no to that. Prohibition plus culture. Government decision and the local culture of the people. If they come together, miracle happens. I'll give you some data from WHO report on alcohol. Just those who do not know for them, India currently, every adult beyond the age of 15 years, the national average is our alcohol consumption is 5.6 liter per capita per year. And this liter is absolute alcohol. So usually, 1 peg of alcohol contains 10 grams of absolute alcohol. I am just approximating. So which means average Indian citizen is drinking 560 pegs of alcohol per year. Now about 50% don't drink, so which means those who drink are drinking double. Now there are countries around, in European countries per capita per year alcohol consumption is 10 liters or more. East European countries consume 14 liters of alcohol per capita per year. And so Russia has brought in some intermediate prohibition. But now look at some other 26 countries in the WHO chart, where alcohol consumption is less than 1 liter per capita per year. Pakistan, 100 ml. Bangladesh, 200 ml. Bhutan, 600 ml. And there are mostly Islamic countries, but also Buddhist countries, where total per capita per year alcohol consumption is less than 1 liter. So it is possible to develop by combining government policies. Not all of them have prohibition, but government policies are very restrictive of alcohol and local culture. Put together, then yes, you can drastically bring down alcohol consumption. Mere prohibition implemented, there are several issues of implementation. I don't know if I answered your question adequately.
I was only saying that somehow the whole country observes prohibition on the Gandhi Day. Can we do it? Though not on all the days, can we at least have few days assigned as prohibition days?
No, I will be very much for that, but whether government will accept or not, I don't know.
So, thank you for a very enlightening talk, and I think we're all grateful to you for talk. My question, mine is an observation, just an observation. You talked about one surrogate ad, which came on the India-Pakistan. It was a surrogate ad, right? Royal Stag. You can't advertise alcohol anymore in India. So it was a surrogate ad for one product, which is in your top 7. There was also surrogate ad for the second product, tobacco, in the form of chewing tobacco, It was a surrogate ad. That was also as high as for alcohol. Both of these were there in that match. That's the only point I wanted to make.
No, your point is absolutely correct. And there actually, to answer your question, sir, that there is a role for government. And we should not let the government off hook of the responsibility. That these kind of surrogate advertisements or government officially promoting sale of alcohol, which happens in most of the southern Indian states, including Maharashtra now. So government definitely has a role, but more on the side of developing policies which should be health protective policies rather than disease promoting policies. There government has more important role.
Amazing talk, sir. So I wanted to ask you, in urban centers in India, and like there is a surge in lifestyle related problems, health issues. So is your model directly transferable to lifestyle related problems? And also in urban centers, the idea of community, I suppose, is slightly weaker as compared to rural places. So are these ideas transferable to lifestyle related problems that urban centers encounter?
Very, very, very important and interesting question. 3 answers. One is that yes, for lifestyle related diseases, the responsibility to some extent lies on the individual. So urban individuals can decide their life choices. Should I eat pizza with cheese? Should I consume alcohol? So on and so forth. Secondly, on 8th of October, I am giving a virtual lecture to a large body of academicians in the US. Very interestingly, do you know what is the topic? Topic is, what are the innovations in developing countries which are applicable to the US? And so they have chosen Search as one such organization which has developed some innovation which may have potential application in the US. So home-based newborn care and community health worker. Is it applicable to the US? To some extent, not entirely, but to some extent, yes. And so many of the health problems, some of the roles can be given to non-professionals, non-doctors, as somebody like community health worker. Very interestingly, if you read history of public health, in 1903-4-5, in New York slum, they employed community health worker for providing maternal child health services to the citizens of the US. So it's only 100 years ago. And so some of these solutions in modified forms. Now when urban woman delivers today, suppose she is an educated person, professional, let's say. After delivery, usually by 2nd day she is discharged. Hospitalization period has to be reduced. So she comes back home. Now most of the women only have one child. So she is the primey. She doesn't have earlier experience of having baby. This is the first time she has a baby, and maybe this is the last time. The couple usually now stops at one child. Now this inexperienced mother, nuclear family, so not necessarily there is another experienced woman, and she is suddenly at home to take care of herself. She is fresh postpartum and the newborn baby, and she doesn't know how to interpret newborn signs. Newborn throws cues. Newborn doesn't speak a language, but newborn does throw cue. But for that mother needs experience. Now how should she take care? And her husband is in a hurry to go on job, join the job and work. And even if he is working from home, he has his work to do. Now concept like urban community health worker for home-based newborn care. Delivery would occur in the hospital. Most of the deliveries occur, that's why. But when the woman comes back on the 2nd day, from 2nd day to 28th day, urban community health worker or Arogya Doot, which probably families will be willing to pay, will be very helpful. So one can apply some of those things even to the urban model, to newborn care also. About heart disease, as I said, most of the decisions actually rest with us. It's after I have got heart attack, no, Arogya Swaraj may not be useful. And you have to go to hospital, ICU, cardiologist, etc., etc. But before I get heart attack. Now, just to end, I said 3 examples. The third example is myself. At the age of 39, I got my first episode of angina. And when I got my first chest pain, I was at the New York airport, coming back from the US after 3 months sabbatical, and huge trunk load of papers and books, etc. I was pushing my cart and suddenly I got my chest pain. And my medical insurance had expired a day earlier. And in the US, without medical insurance to get admitted in the hospital. And so I decided to take risk. I sat in the aeroplane, came back alive in India, and then my real journey started. I had developed heart disease at such earlier age. I couldn't understand why. I was a social worker. My grandparents lived up to the age of 95. I was a physician. Half of my MD training, I was registrar of the intensive care unit, so treating all myocardial infarctions. I was supposed to be a social worker who was working among tribal people, so why should I get heart attack? And a deep phase of introspection, very painful, very painful. It's good, it's easy to pass judgments on patient, but when you are the patient and you are the doctor, examining your own past behavior and life as to where did I go wrong? And then I gradually discovered what mistakes I did. I don't want to bore you with all those things. But then, by changing my own lifestyle, apart from angioplasty, which I unfortunately did need, I couldn't escape that. But by changing my lifestyle, I am still alive 30 years later and still working. So yes, individual has a role, and I have written a book on that. I'm not promoting this book, but because this question is asked, my struggle with my own heart attack and how did I come out of it by changing lifestyle and finding solutions. That book is titled My Enlightening Heart Disease. Because in hindsight, I really think that it was a boon that I developed heart attack. Otherwise, I would have continued in the same vein. So we can change our behaviors. That book is bestseller in Maharashtra for the past 25 years. And the cardiologists, when they discharge patients with heart attack from ICU, they prescribe, officially prescribe on prescription pad this book. It is translated now into English. My point is, of course, that we have enormous role to play in either preventing or even after you have developed disease for secondary prevention, managing your own illness at home.
If there are no other questions, let's thank the speaker for the wonderful talk and interaction.
Thank you.
So I'd like to invite our director, Professor Tarun Saurodip, to hand over a little memento.
At the right spot.
Yes. Nowadays, even at the marriage time, photographer decides. Thank you. Thank you.
Told you about the 75 years, there was a commemorative stamp.
Thank you.
So also the dinner is arranged outside, so I'd like to invite. There was. So it is still outside, right? Not on Astro Terrace. We have to confirm. Okay. Downstairs. Okay. Yeah. Everyone please join for dinner after.
Experience.
Thank you.